In the October 7th issue of JACC, a look at the changing landscape of advanced heart failure therapeutics. And it's an editorial comment on national trends in the utilization of acute mechanical circulatory support, incidence, outcomes, and cost analysis. And I'm with Christopher O'Connor, MD, co-author of the editorial, and from Duke University, and importantly, editor-in-chief of JACC Heart Failure. Thank you very much for talking. I think the first thing I wanted to talk about is a little bit about this paper. So just where are we right now? What kind of national trends were they finding in this paper in JACC?
Rick, this is a very important paper because it's taking a look at our national inpatient sample, an administrative database that looks at procedures and costs and activity in the hospital. And what these authors have done is looked at the trends of the use of acute mechanical support devices. And what they found is that over the most recent time period compared to a time period prior to 2008, there's been over 1,000% increase in these temporary mechanical support devices for the treatment of patients with cardiogenic shock and advanced heart disease. And so that's an astonishing observation, I think, and not one that's been reported at all, really, recently.
So in the paper, though, that you co-authored, I should say, with Joseph Rogers, who's also from Duke, and you write, going forward, care must be taken to avoid use of temporary MCS devices as a crutch.
Well, we made that quote, and we stand by that. It's important that while this trend is occurring rapidly, this use of these devices, we don't want people to embark on strategies and use of devices that perhaps haven't been proven to alter important clinical outcomes. So what this paper shows is a observational database, but where are the randomized controlled trials? We did the review of the trial of intra-aortic balloon pump in cardiogenic shock, the shock trial, in which there was no advantage of intra-aortic balloon pump on survival in cardiogenic shock of patients with MI, and that was a surprise. And we again challenged the community of cardiologists to make sure that we do randomized controlled clinical trials, because everybody was using balloon pumps in that setting. And the German investigators did this study and found no benefit, and so.
I mean, that's actually something you would say about devices in general. Where are the randomized trials for many of these?
Right.
We've got a lot of data, but not necessarily randomized trials.
Well, and yet we can do it. As a community, we're probably some of the best at believing in randomized trials, the equipoise. You think about the first LVAD trials that we did, rematch. Hard to believe that we could do those types of trials. And those types of trials of the durable permanent mechanical support trials are going forward with very good enrollment, and people are engaged in that process. The temporary space is more complicated because you have a patient in front of you with cardiogenic shock, and you're saying, okay, what do I do? And here's a way to improve the hemodynamics, even better than a balloon pump, and yet do the hemodynamics improvement temporarily translate to important clinical outcomes. This paper had some interesting insight, the increased use, the reduction in mortality over the same time, reduction in cost over the same time, more people getting out of the hospital. There's some good insight here.
I mean, that's kind of important because you can't talk about these devices today, as expensive as they are, without talking about cost utilization and cost effectiveness. So they did this analysis in this paper by a stretch of all, right?
Yeah.
And what did they find?
Well, what they found is that costs went significantly down, but they showed only the tip of the iceberg, because what happened to the patient, the journey of the patient over the next year or so? That's what we need to know. More people got out of the hospital. Costs appear to be going down. Obviously, if you shorten length of stay, you're going to get a reduction in costs. But I want to know more about rehospitalization rates that are occurring over the next subsequent year, and what about the utilization of permanent devices? These devices are really bridges. So are we augmenting the use of permanent devices and using two devices instead of maybe going more to the definitive device early on? That's another question that has to be raised. So there's a lot of questions raised by this paper, and I think
Any predictions on what's going on in the next couple of years? We're going to see far more use?
I think we're going to see continued use, continued growth. We're going to see continued refinement of the technology.
Right.
Technology will get better, more facile, easier. These devices will get smaller. But the community of cardiologists are going to have to push for the randomized controlled clinical trials. What's the exact setting? What's the duration? Who do you go to permanent or not? How do you wean these devices?
Well, it's fascinating. The paper, the para papers actually, because we're talking about the original paper and then the editorial comment by Dr. O'Connor, and that's in the October 7th issue of JACC. Please check both of them out. For CardioSource World News, I'm Executive Editor Rick McGuire.